So hello guys, welcome to the Meded Clinic. So today we are going to learn a short examination from orthopedics. So today we are going to learn about examination elbow joint. So before that, just a clearance from you all whether it is audible, visible. Any doubts from the last class you want to know? So I hope it is all clear from my side. You can hear properly, see properly. Okay then. So now let's moving on to the examination of elbow joint. Today we are going to learn about the elbow joint. And for the UGs, this is supposed to be the most important topic because this topic is usually from orthopedics. It is the short case which we'll have, right? They will give you a short case in the exam and they some case which is usually related to elbow. And examination of the elbow is very important case taking. So I hope you will all pay a little more attention and make the best use of this class. Good evening, Prasad. Good evening, NVK. And before that, a very happy Valentine's Day to you all. So, what I wanted to always learn is from the basics. Like, if you are reading something like the examination of the elbow joint, I always believe that you have to have this anatomy in your mind very clearly so that you know what to examine and what to look for. Only if your brain knows it, then only your eyes can see it, right? So, that is why I have come up. Gansham, good morning. I'm sorry, good evening. So I have come up with the anatomy first because this is there are very much important structures which are there around the elbow that you have to know. So starting from the elbow. So elbow is what joint? Elbow is a hinge joint, right? And as any hinge joint, it also has the movement which can occur only in one plane, that is flexion and extension, right? What we have learned since our first year. But when we read anatomy in detail, we also know that elbow joint is not a simple hinge joint. It doesn't have only a flexion and extension, but it has other components also. So what do you think this elbow hinge joint is made up of? So it is made up of the humerus and the ulna, right? So it is a humero-ulnar joint, but not to forget its friend which is there supporting it all the time, the radius, right? So there is a radio-ulnar joint which is present and the humero-ulnar. So whenever you are examining, you have to be careful in the mind that which structure you are examining and for what you are examining the joint. Okay, right? And now, so these are some of the important structures which you have to identify. So first, let us talk about the distal humerus. So distal humerus is again a broad segment like this. The shaft extend into the distal humerus like this, right? And then you have two condyles and then the epicondyles. What we are interested more is the epicondyles. So these are some prominent points over the condyles. So these epicondyles are present on both the sides of the humerus, right? So that means a medial epicondyle and a lateral epicondyle, right? This is medial epicondyle and the lateral epicondyle. And the end of the humerus, we have certain important structure. This you have to remember. So on the medial side, we have trochlea. You can see the structure, it is like this. So this is the trochlea, right? And then on the radial side, we have capitulum. So this you have to remember, capitulum and the trochlea. So whenever they talk about the radiocapitular joint and they talk about the ulnar trochlea, right? So this is the trochlea, which is present on the medial aspect, and this is the capitulum. So this trochlea articulates with the ulna. This trochlea will articulate with the ulna, and this capitulum will articulate with the radial head. It articulates with the radial head, right? And then this is what, these are two fossas what we have right here. One is coronoid fossa and the second one is the radial fossa, right? So one we have the coronoid fossa, the second one is the radial fossa. And what is this? This is the coronoid structure. Is that clear? And now if you see this particular diagram, in this you can see these are supported by the collateral ligaments, which is the medial aspect called as the medial collateral ligament, and on the lateral we have one more, this is called the lateral collateral, right? So not to learn more detail about the ligamentous structures around the elbow joint, but for now remember all these bony structures which are very, very, very important. As we go on, this is what you're dealing with, right? And now this is in the extended arm. So whenever you extend the arm, this is what you see. So these are the bony structures what you can feel. And when you flex, so this is what you get. So when you flex, what you can feel is this is the humerus and this is the capitulum, right? Right, capitulum, and this is the radial head. So this is the trochlea. This is the trochlear notch, right? So this is the trochlear notch, and this is an important structure which is called as olecranon. Understood? So whenever you're flexing the joint, you can see this prominent point as the olecranon. On the lateral aspect, this prominent point as a lateral epicondyle, and on the medial side, you can see this as the medial epicondyle. So these are the three bony prominences what they usually talk about in your elbow. So this is what has to get into your mind. Okay, good so far? And here, whenever they talk about the radial head, what you have to remember is this radial head is enclosed in an annular ligament, which is very, very important. So this is important because it is enclosed in a annular ligament. And I'll tell you why this is very important to remember, because this is again associated with something else, which we'll learn later. Okay, so this is about the basic anatomy, which you have to remember. And so this is one of the important diagram which you have to remember. So I have told you that this humerus is articulating with the ulna. You see like this. Understood? And now there are two important structures on the anterior aspect. There is brachialis. On the posterior, it is tricep. So this is for your flexion of the elbow, and this is for your extension of the elbow. So this is how you see it on. Okay. So now this articulation, why I have taken this diagram is you have to concentrate on few important things here. One on the anterior aspect, two on the posterior aspect. So anterior aspect is this extension of the synovium, which is called the synovial pouch, extra synovial pouch, right? And these are the two fat pads which you can see here. So whenever you have a swelling, you can see fullness of this pouches and the pads on the ultrasound. So this on the X-ray also. So this is the fat pad and this is the extra synovial pouch. On the anterior aspect, you can see the synovium extension, and on the posterior aspect, this asterisk denotes the posterior fat pad sign. Okay. So this is about the elbow anatomy. We are still dealing about the anatomy. Okay. Now let us start the case discussion. So as we all know, any case discussion, especially when it comes to case taking, again it should always start with the history, right? And in case of your elbow joint, usually they might give you a deformity, because what is the famous deformity which we see in the elbow joint? Any one of you? Most important deformity we see in the elbow joint? So this deformity is called either as cubitus varus or cubitus. So usually they give with a deformity elbow cases, or they can give you with another deformity called as claw hand, right? And then they can ask you regarding supracondylar fracture of humerus, which is very, very important. So you have to be thorough with this supracondylar fracture humerus, right? And they can ask you questions related to tennis elbow, similarly golfer's elbow, right? So whenever you have this elbow case, I mean, whenever you they after reading that sheet that came to know that you are going to deal with the elbow case, these are the things which you have to put in mind. So once they, even though the case might be something else also, it may be just a effusion of the elbow, it may just a synovial swelling of the elbow, but again they don't ask you much about them, and again they will come back asking you about what is cubitus varus, what is valgus, what is claw hand, and how do you develop claw hand in case of elbow injury. And any question, any elbow case, they don't complete the case without asking about your supracondylar fracture humerus. Very, very important. And the friend of supracondylar humerus is your lateral condylar humerus. So that also one or two questions will be there on this lateral condylar humerus, right? So these are the things which you have to deal with whenever you're dealing with the elbow case. So you will take the history accordingly. So whenever there is a deformity, so you usually ask the onset of the deformity, the progression of the deformity, right? And the most important thing what you have to include in the history is the functional limitations. So you have to ask the patient what is that it is bothering him. So what are the functional limitations? So what are the activities which he is not able to do? Right? So the deformity is a very important thing. So you have to deal with the onset. So how did it actually start, and is it progressing? So how much has it progressed from the onset, and then what are the functional limitations, and what could be the possible uh, associated symptoms with it? Like for example, if you see a deformity of the claw hand, right? So you can ask whether there is a tingling sensation, which is happening in the little finger. So what are the associated symptoms? Okay, so these are the questions you put for the deformity, right? And then if there is some trauma related causing this deformity, then you put the details of the trauma, right? So details of the trauma, like for example, let us assume that there is a case of cubitus varus, that is supracondylar fracture humerus, right? So you will ask some details about the supracondylar fracture humerus. So when, how did it occur? What was the treatment given to it? So mostly you have to include the treatment modality, and then you have to include the points of immobilization techniques, like how did it immobilize, and what is the treatment given to it, and what are the complications they have encountered during this treatment of traumatic condition, right? So these are the important points which you have to note. Is that clear? Any doubts till now? So that is immobilization protocol, and then you will include the any complications which they have encountered during the treatment of that particular trauma, right? So this is about the history taking. Are you following? I need a thumbs up from the students. Okay, hope you're all following. And then starts our examination, right? Then starts our examination. So as we all know in ortho, the main thing is in examination, you have to always start with the attitude or the deformity. Not to confuse, attitude is the position of the ease which the patient comes, and it can be corrected. But the deformity is one which cannot be corrected, right? So if at all you see there is an attitude of the patient, like for example cubitus varus, or initially you think it is an attitude, so you can just explain the patient's hand. So how do you do that? You have to ask the patient to stand and put his both the limbs beside with elbow extended and forearms supinated. So this is how you examine the patient. So completely have to stand in the anatomical position with the arms hanging by side with elbow completely extended and forearm completely supinated. So whenever you ask the patient to stand like this, then you can observe an angle in the so you can observe the angle at the elbow. And what is this angle called? Yes. What is this angle called? Which is the angle made by the long axis of the forearm and long axis of the arm. So what is this angle called? Yes. This angle is called as the carrying angle. Somewhere around 11 degrees to 15 degrees, which is more in females. Right, so this is the carrying angle. So carrying angle is what? An angle which is between the, so now whenever you stand straight like this, so you get a long axis to the arm and long axis, yes, exactly center of the arm and center of the forearm. So this is called, so this is called the carrying angle. Okay, I'm fine. Happy Valentine's Day to you. Now I'm not in age of celebrating the Valentine's Day. Instead, I should actually be waiting for the Mother's Day. But anyways, thanks for wishing me. But I'm waiting for the answers. So that angle is called the carrying angle. This is the one which is expected in case of your attitude, right? Attitude of the elbow. And sometimes whenever there is an injury, so there is some trauma involved, the elbow can be flexed. So you have to put that. So we can see an attitude, and this attitude you have to see from the front, from the side, and from the back, right? So there you can note that whatever is the attitude, usually we see the elbow flexion position, and then we see this carrying angle. Okay, so whenever there is an injury, you see that there is a flexion position. So that is what you have to comment on. And then coming to the swelling. So swelling, again, you have to see from the front, from the back, and from the sideward. Right, from the front, what you usually see is the anterior aspect. So this is the cubital fossa. From the back, you have to look for the olecranon. You have to look for the olecranon, right? So sometimes in case of olecranon fractures or supracondylar humerus fractures, what you observe is this process becomes prominent, right? So the olecranon process becomes very, very prominent. So then you have to think about whether this is a fracture or this could be a supracondylar fracture or a fracture. So you have to see for the olecranon process. So this is the olecranon, right? And sometimes there could be just a swelling, for example, in the student's bursa. So what do you mean by student's bursa? Or rather, student's bursitis. So this is the olecranon bursa. Friction of flexed elbow onto the table. So the student usually sits like this and listen to the class, right? So because of that sitting, there would be some friction between the table and the bursar, leading to what is called as student's bursitis. Okay. Table. Right. So that is your student's bursitis. And from the sidewards, sometimes you can see the fullness again in case of your fractures, right? So this is how you have to look for the swelling. You have to look for the attitude, right? And then comes the deformity. So deformity, usually I have told you that it could be a cubitus, varus deformity, and it could be a cubitus, valgus deformity, or a flexion deformity. Right? So when you say it is cubitus varus or when you say it is cubitus valgus. So for this, you can take the example of this. So this is what is your carrying angle. So that is what I've told you in the extended and the supinated arm. You draw a long axis along the humerus and long axis along the forearm, which gives you a carrying angle, right? So if this carrying angle is normal, so it is a normal carrying angle, or this can be increased or decreased. Whenever this carrying angle is increased, you call this as cubitus valgus. And whenever this carrying angle is decreased, you call this as cubitus varus. Right? So this is also called as what? This is also called as your gun stock deformity. And where this is usually seen, this is usually seen in case of your supracondylar fracture humerus. And here what you can expect in case of valgus, what we see is tardy ulnar nerve palsy. And then what you can, this can happen in case of your lateral condylar fracture, right? So these are the two things which you have to remember in case of your elbow examination, especially in inspection. So now you're asking the patient, now you can measure the carrying angle, and now you will say whether this is a varus or a valgus deformity. So in case of increased carrying angle, what you see is a valgus deformity that is usually occurred as a result of a childhood trauma, and that trauma is mainly your lateral condylar fracture humerus. And not I think you all know that this is an articular fracture, right? And this is an extra articular fracture that you have to remember. So this is a supracondylar fracture, varus or a gunstock deformity, which is usually put in the exam, right? Otherwise, patient might come with a claw hand deformity like this. And this claw hand can be a result of a lateral condylar fracture. And then you have to again examine the elbow joint in this case also. Right. So this is the attitude or the deformity where you will examine or where you will write entirely regarding this, and then you will write about any swellings or the prominence which is felt there. So that completes your inspection. And sometimes, not to forget, one more important thing in case of inspection, it is about your muscle wasting. So whenever you see chronic conditions, so you have to always comment upon your muscle wasting, and this should always be compared to the opposite side, right? So in ortho, we are usually blessed with two sides, right? Right and left, even upper limb and the lower limb, right? So that is why you have to compare to the opposite side, and then you have to just inspect, because we're still in inspection. This is all about your assumptions by looking at the patient, right? And then comes your palpation. So after inspection, it is your palpation. So in the palpation, you are going to, what is the main aim of palpation? So first line, what is there? Confirming all the inspectory. So palpation is mainly confirming all the inspectory findings, right? So now first you will measure the carrying angle in case of your deformity, right? And then the most important thing again in palpation is your temperature and your tenderness. Then examining all the bony prominences, right? And then most important is your 3-point relationship in case of your elbow, right? So these are the points which you have to remember. So first, always you look for the temperature, tenderness, examining the bony prominences, and 3 bony relation, right? And further, palpating the nerves. So especially the ulnar nerve, which can be felt easily on the medial epicondyle. Okay, on the medial epicondyle region. Okay, right? So now temperature and tenderness usually in case of elbow joint not very important, because I have told you elbow joint are mainly deformities. So whatever we encounter in our exam is mainly regarding the deformities, but temperature is involving whenever you deal with arthritis, which is usually unusual in case of elbow, right? And then tenderness is important in case of your fractures. In case of your fractures, tenderness is very important. Again, tenderness is important in case of your tennis elbow, whenever you're commenting on tennis elbow or golfer's elbow. And student bursitis. So these are the inflammatory condition, right? So these are the areas where the tenderness plays an important role. But what is the main important thing? Because I have told you we will always deal with deformities in case of your elbow. It is the 3-point bony relationship and the examining all the bony prominences. Now tell me, what are all the bony prominences you're going to look for in case of your elbow joint? Yes, it's time for you to answer now. What is the, or what are all the bony prominences you look for? I've already told you in the first slide. Yes? Shiv, what are the bony prominences you will look for in case of elbow? Come on, even if you don't answer it right, that is okay. But keep answering so that whenever you interact, the memory retention is more. Yes, I'm waiting for the answers. So first are the two epicondyles, that is the medial epicondyle and the lateral epicondyle. Then you will palpate for the radial head and then for your olecranon. So these are the bony prominences which you look for, right? Is it clear, guys? I'm audible to you all? Please say yes for that. So the bony prominences are the medial epicondyle, lateral epicondyle, the radial head and the olecranon. So now you have to learn how can you palpate these structures, right? So first let us understand palpating the medial epicondyle and the lateral epicondyle. So these two are palpated whenever the elbow is in flexion. So now what you do, you put the elbow in flexion so that they become more prominent, and on the medial side you come along the distal humerus like this, and at the end of the humerus you will prominent there. So whenever you're doing it on the lateral aspect, that would your lateral epicondyle, and similarly you come across the distal humerus on the lateral medial aspect, and then you will find a bony prominence, right? So bony protrusion, something like that. So that is your medial epicondyle. Now this is my medial epicondyle, and now this is my lateral epicondyle, right? Like, so on the extension also you can find, but on the flexion they will be more prominent. This is the medial, lateral, and now this bony prominence is your olecranon. So this is your olecranon. So once you palpate all these structures, so you will palpate the olecranon, the medial epicondyle, lateral epicondyle, right? And now this, what it forms? What shape it gives us on flexion? So this gives a triangle, right? Now, not to break your head whether this is an isosceles triangle or it is an equilateral triangle, nothing like that. That is a triangle. It is neither isosceles nor equilateral. What you have to remember is the medial epicondyle and the lateral epicondyle is the longest distance, right? And then the medial epicondyle and the olecranon, the shortest distance. This is what you have to remember, right? So whenever you're drawing a triangle, remember that the medial epicondyle, lateral epicondyle, the length has to be more, and the shorter distance is between your olecranon and the medial epicondyle. So that is how you palpate these three bony structures. So medial epicondyle, lateral epicondyle, and the olecranon. So now we are done with the three things. So what is the main important thing we are left out with? We are left out with the palpation of the radial head. So how do we do that? So we are going to palpate the radial head. So how are we going to do the palpation of the radial head? So as you see in the picture above, so now your elbow is flexed like this. So the flex elbow, and then you will try to palpate first the lateral epicondyle. So now you will palpate the lateral epicondyle as we have done identifying the lateral epicondyle. Then you just slide your thumb finger below the lateral epicondyle, and then you will palpate one more important bony structure, which is your radial head, right? So this is your radial head. And then how do you confirm the radial head? How do you confirm the radial head, right? Confirming the radial head, now what you do, you will grab the person's hand like this. Now with the other hand you will hold the person's hand or wrist, and what you do, you perform pronation and supination. So you perform pronation and supination movements which are important for the radial head, right? So radial head is the one important structure which is involved in doing this pronation and supination movements, right? So once you do this pronation and supination movements like this, so first you will, what you will do, you will palpate the lateral epicondyle. So now you come across this bony ridge, and then you palpate the bony prominence at the end, called the lateral epicondyle, and then you come little down to it, you can find more important radial one more important bony structures. And once you are on that particular bony structure, what you do is you will pronate and supinate. You will pronate and supinate. Whenever you're doing this pronation and supination, what you can feel under your thumb, that movement of that pronation and supination, and then you confirm that that is your radial head. So this is the method how you are going to identify the radial head. And in the case of elbow joint, this is the short question they're going to ask you. Show us the demonstration or explain us how do you palpate the radial head in an elbow joint examination. So this is how you have to make sure. So you have to always tell that you're going to first identify the lateral epicondyle, then just move your finger below that and you will feel another bony prominence, that is your radial head, and you're going to confirm by doing the pronation and movement as radial head is involved in such movements. Okay, and that is how you confirm that it is your radial head. So this is all you will see for your bony prominences. That is what I have told you, right? And then the most important thing which you have to remember in case of your elbow joint examination is the three bony point relationship. So this we have already discussed. So now we have palpated the epicondyle, so medial epicondyle and the lateral epicondyle, right? And then you're going to palpate the olecranon. So this is your olecranon. right? So this relationship observed only in flexion, that you have to remember, observed only in flexion. On extension, they become a straight line. On extension, they become a straight line. So this is your flexed position. This is your extended position. So on extended position, it is a straight line. So in straight line, you can see this is your medial epicondyle, right? So this is your medial epicondyle. This is your lateral sorry, this is would be a lateral radial head, no? So lateral epicondyle, the medial epicondyle, and your olecranon. So all this becomes a straight line in case of your extended elbow. And this is on flexion of elbow. This forms a triangle. This forms. And what is important for us? When it is maintained and when it is disturbed. So that is what is the question behind it. So why are you doing this? So to identify when it is maintained. So this 3-point bony relationship is always maintained whenever the condyles are not involved in any fractures. So for example, the supracondylar fracture. So supracondylar fracture humerus, you see that's this three-point bony relationship is maintained. So this is 3-point bony relationship, right? And then when it is disturbed in case of lateral condylar fracture humerus, and it is disturbed in medial condylar fracture humerus, and then intercondylar fracture. So these are the areas where this three-point bony relationship is disturbed, and it is very much well maintained in supracondylar humerus. So this is very important question. You need also this is asked, right? And now in the examination of your elbow joint also, once you comment on the 3-point bony relationship, then there would definitely be a question that why are you actually doing this relationship, and when it is maintained, and what are the cases it gets disturbed, right? So these are the answers they usually expect from you. And then once the palpation is done, so palpation, you're telling about the tenderness, right? So you will tell about the tenderness. If at all it is some inflammatory condition, you can talk about the temperature, and then you will palpate all the bony prominences like the lateral epicondyle, the medial, the olecranon, and then you will comment on it, and then you will palpate the radial head, right? So once you palpate the radial head, then you're going to comment on the radial is maintained or tender, or what is the thing with it, right? And then you're going to comment upon the 3-point bony relation. So these are the 3 points which you have to measure and tell them that it is maintained or disturbed, right? So in the measurement, so first thing what you're going to do is going to calculate the carrying angle, and if it is a varus or a valgus, going to calculate that also. So you're going to comment on the angle as well, and then you're going to measure the triangle, and finally you're going to measure the measurement arm and measurement of forearm, right? So how do you measure the arm and the forearm? So in the case of arm, you take a flexed elbow, so elbow inflection, so angle of acromion to lateral epicondyle. That is the measurement of your arm. And then measurement of forearm from the lateral epicondyle, that is always the tip of the lateral epicondyle to the radial styloid tip. So this is how you will measure. So usually in case of your supracondylar fracture, your arm length is reduced, right? In case of forearm, then it could be, example could be your posterior dislocation. So in case of posterior dislocation, again your length of the forearm is reduced, right? Reduced in case of supracondylar humerus fracture. Right, so these are the two important things you have to remember. So two important examples. So angle, why do you usually measure? So we measure from the acromion. So this is the angle of the acromion. You're going to palpate the acromion and you're going to measure the angle of the acromion to the lateral epicondyle. So again, lateral epicondyle, and from the lateral epicondyle to the radial styloid process. So your radial styloid process on the lateral aspect. So this is how you measure the measurements of the arm, the foot, right? Fine. Any doubts? So everything you have to mark. So whenever you're doing something, you have to always mark. So that would tell you that you have actually measured it. So whenever you're doing anything on the body, so for example, you're examining the medial epicondyle, then just put a pencil mark or a pen mark. This tells you that this is your epicondyle and this is your lateral epicondyle. Similarly, mark the angle of the acromion first. So you have to mark the angle of the acromion first, and then you're going to mark the lateral epicondyle and then the radial styloid process. Right, so when you mark all this and measure, it will give the accuracy, like when even the examiner sees body's patient body, then he will be satisfied, like looking at the marks, at least he will be like, you have attempted to measure the length of the arm, forearm. And then they will ask you when it is where do you see the decreased length in the arm and forearm. Does that actually affect you? It will not actually affect you, because the thing is here, the elbows, the shoulders are not connected like the two lower limbs in the pelvis. So whenever there is a decrease in the length in case of one leg, it usually affects the other leg. But that is not the case in case of your upper limbs. Upper limbs are not connected, they are each individuals, right? So even the length is reduced, you only feel shortening of one limb, but it is not affecting the other limb, right? So that is the thing you have to remember in case of your measurements in case of your elbow joint, right? And then finally, movements. So these are the movements. So again, we all know that it is a complex hinge joint, right? And then you have two important movements, the flexion and the extend, right? So the flexion, the coronoid goes and sits into the coronoid fossa, it is limited, and at the back the olecranon goes and sits in the olecranon fossa, again it is limited. So this is the flexion, and this is the flexion, and your extension. So extension, you can see straight line, it is a 180 degrees, right? So this is the extension and this is the flexion, right? And not to forget that again, so there are two important things you have dealing with the elbow. So one is your ulnohumeral joint, and the second one is the radio-ulnar joint. So in this radio-ulnar joint, so that is your proximal radio-ulnar joint. So this proximal ulnar joint, where the radial head is involved, there are again two movements which happen. So one is your supination, the second one is your pronation. So these are the very important movements which you have to remember in case of your elbow joint. So first, what you do, you always put your two. So this is how you examine. So now you put your arms like this, right? And then you ask the patient to do your flexion and extension. For flexion and extension. So usually sidewards you can feel it more, right? So this is the piece, and you can see my arm is completely flexing. So the surface, right? Complete flexion, right? Any flexion. So if you say that there is some restriction, tell the flexion. right? So the elbow is only flexing up to 9, so it is only 10 or like that. And now extension, so this is 0 degrees extension. So now if it is like this, if it is not, then you say there is a 10 degrees lag in, right? That is how you comment. And then coming to your supination and pronation, how do you do it? So you ask, actually put the inflection like this, and now you hold a pen in 2 hands, right? You hold the pen in 2 hands, and then you ask the patient to supination. Supination is this movement. So completely the radial head sits beside the supination. And this is pronation. Now the radial head moves forward over the ulna. So the radius comes over the ulna. So this is your pronation. You can see, right? So this is your pronation and this is your supination. So this is how you ask the patient to do the supination and pronation. And only in the elbow flexed position, not in the elbow extended. So in the elbow extended, you're doing like this. The movement is actually occurring at your shoulder level, not at your elbow level, right? So to confirm the supination and is perfect and it is normal, you have to always compare it with the opposite side. So whenever there is some problem in the radial head or some problem in the malunion, so what happens is there would be some restriction. So this hand, it completely goes into pronation and might come only up to mid pro. So then you will say there is a restricted pronation. So sometimes it can go only up to like this mid pro. Then it is a restricted supination. So please remember, this is very important question usually asked by all the examiners to show how do you examine supination and pronation, right? So the first and foremost thing is put your arms by the side, elbow in flexion position. Then you do with this with some pen or pencil in your hand so that you can point it properly. So the pronation, the supination, right? So how you examine the two important movements. One is flexion elbow and extension, and the second one is your supination and pronation. And not to forget, these movements ought to be discussed in two varieties. So one is your active, the second one is your passive. So what is that important condition where you see there is a restriction in both flexion and extension, and it is the both in active and passive movements. So whenever you see there is a restriction in both active and passive, that means there is some bony component involved. The most important example which you have to remember is myositis. What is myositis ossificans? So myositis ossificans is a condition where due to repeated massaging over the muscle gets overstimulated and it gets calcified. And what is that important muscle in case of elbow? And that is your brachialis. And not to forget, elbow is one of the most important joint to present with myositis ossificans, usually post-trauma or post-massage. Right? So this is also one of the important question they will ask you regarding your movement. So whenever you talk about the movement, so these are the questions which you have to put behind your theory, right? So whatever you're reading, you have to read accordingly. So whenever you're doing movements, then they will ask you flexion and extension is occurring between which joint. So you can put that as ulnohumeral joint, and then they can ask you the radio ulnar joint does what a type of movement. Then the answer would be pronation and then they will ask you what are the two types of movement. So one is active movement, which is done by the patient. The second one is passive. So if both active and passive are restricted, there is a bony component which is involved in it. For example, it is myositis ossificans. But if there is only active movement, which is active movements which are restricted and passive can increase the little further. So that is, then you can think there is some soft tissue involved. Right? So both active and passive restricted, it is nothing but your bony block. This is called as a bony block, and the most common example and the most common joint which is to undergo myositis ossificans is your elbow joint. right? And once you answer this, then what is the second joint which is involved in myositis ossificans? And that would be your hip joint. So once you have answered all these questions, they might again ask you, then what is the second joint? So that is your hip joint. That about the movements, right? So movements you have to comment, that is your flexion, extension, the pronation, and the supination. Okay, so that is about the measurement. Then this is about the movement. And finally, you will conclude a elbow case only by commenting upon the neurovascular structure. Very, very important, right? So you comment upon the neurovascular status or neurovascular structure, right? So here in the elbow joint, if you see, there are the three important nerves around the elbow joint. So but the most important one they usually ask about is the ulnar nerve, and the second one would be your median nerve, right? And the third is your radial nerve, right? So whenever you're talking about the elbow joint, always comment about the nerve, and that is also the ulnar nerve, which is present on the medial aspect. And how do you palpate the ulnar nerve? Again, on extension, you can't palpate the ulnar nerve. You have to flex it to 30 degrees of flexion. You're going to flex it, and on the medial condyle, you will palpate. And just after palpating the medial condyle, you rub the thickened structure. So you can feel something, a thickened structure, a cord-like structure over the medial epicondyle. So you will do this movement, right? Will just palpate this thickened cord over the medial epicondyle. Rub that thickened cord. So that is your ulnar nerve. So whenever you feel that ulnar nerve, sometimes you can thickened. That is usually observed in case of leprosy. Medial aspect over the medial epicondyle, you will feel what is the most important ulnar nerve, right? That is, you have to comment upon the, okay? And then the most important thing again, you have to comment upon your pulses. So once the nerves are done, and how do you check for the nerve? In ulnar nerve, you all know it supplies the little finger and the ring finger, right? So you have to always check for the claw hand. So if you think there is a claw hand on examination, you have to always check for thickening of the ulnar nerve, right? So that is how you check for the involvement of the ulnar nerve. So the patient can either present with claw hand or he can present with pain around the medial epicondyle, right? And this is only peripheral nerve which you can palpate. And for median nerve, what you check? For median nerve, you look for the pointing index, right? So median nerve, you look for the pointing index. So these are the two important nerves which you have to look. So you have to always check for pointing index, that is median nerve involvement, or a claw hand, which is a ulnar nerve, involvement in case, right? And coming to the pulses, pulses always complete the case of the elbow with the pulsation. That is, you have to feel for the radial artery. So in case of again the supracondylar humerus fracture, so supracondylar humerus fracture, there is always a chance of involvement of the brachial artery. So whenever there is a fracture in the arm, so here you can see, though, this is the fracture of the supracondylar humerus, and then you see this point is affecting the brachial artery. So there would be a kink in the brachial artery, and sometimes you can feel that radial pulsations absent. Case of supracondylar humerus fracture. So that is the important thing. So you have to always feel for the radial artery. You have to always check for the ulnar nerve. How do you check for the ulnar nerve? Over the medial epicondyle or the medial aspect, and this is the only peripheral nerve which is palpable. And how do you going to check for median nerve? So median nerve, you all know that it involves the 3.5 fingers, right? Long flexors are supplied by the median nerve, so it might result in the pointing, right? That is about the nerves and the vessels which you have to check. Fine. So this is about the supracondylar humerus. So as I am expecting, so this is the deformity usually they present to. So this is the cubitus varus deformity. So this cubitus varus deformity is what you're going to deal with. So how do you going to deal with? You will always put up first the attitude that it is varus or the deformity. So you will say there is an increased, so there is a decreased carrying angle on attitude or deformity. Then you will observe for swellings, usually it's a chronic case, so there are no swellings present. Some amount of muscle wasting can be there because it is a chronic case. So you will comment comparing to the opposite side. So there is some amount of the muscle wasting which is there. And again, palpation, you will measure the carrying angle and then you will look for the what in palpation. You look for the bony prominences. So medial epicondyle, lateral epicondyle, olecranon, radial head, all these prominences you will look and you will comment on. Right, and then you will look for the 3-point bony relationship. Then you will write it as maintained because we are dealing with the cubitus varus, and you already know that this would be a result of the supracondylar fracture, which is an extra articular. So it is above the condyles. So this will result in maintenance of the 3-point bony relationship. Right. So now they might put some questions which are related to your supracondylar fracture humerus. So this is the theory which you have to read when you go for a cubitus varus. So the theory is this is usually seen in 4 to 8 years of age, right? So 4 to 8 years of age group, and as a result of fall on outstretched hand, right? So fall on outstretched hand, that it is results in the above the condyles fracture. And then this is Salter-Harris type 2. So now you can go back to read about Salter-Harris. So what is the Salter-Harris? So this is a classification name. Whenever it involves the growth plate. So whenever you see there is an involvement of the growth plate, you have to classify this according to the Salter-Harris. So coming to the supracondylar, it is Salter-Harris type 2 type of fracture. Okay. And then because it is an extra articular fracture, you usually don't see what? Because it is an extra articular fracture, usually the complication of this would be a malunion. Right, so this is a malunion resulting in this deformity, and this is usually called as your gun stock deformity. Called your gun stock deformity. Right. So this is usually called your gun stock deformity, right? And what are the other complications you expect? So the early complications, what we usually see here is the involvement of the brachial artery, and then the involvement of the anterior interosseous nerve, which is more than your median nerve involvement. Then comes your ulnar nerve, and finally your radial nerve, right? Because of the involvement of the nerve and the vessel. So you can also expect compartment syndrome. And one of the most important late complication is your BIC, Bookman's ischemic contracture, because of the involvement of the brachial artery. So these are all the various complications with this supracondylar fracture. And how do you treat it? So usually we treat with the closed reduction plus K-wires fixation. So this is how we deal with closed reduction. So that is, you do reduction and then you put two K-wires. So we put two K-wires. This is called the K-wires fixation. So this is about most important things which they can ask you about the supracondylar, right? And then if you have done really well, then they will go to the X-rays, right? So in the X-rays, this is very, very important because there are some important points which you have to remember in the X-rays. The first one is the fat pad sign. The second one is the anterior humeral line. So whenever you draw an anterior humeral line, so this is your anterior humeral line. So whenever you draw a line along the anterior aspect of the humerus, which is called the anterior humeral line, you're going to bisect the capitulum like. So this is how you bisect the capitulum. This is the capitulum, and now we are going to bisect this way, right? This is the, so whenever you don't bisect the capitulum, not bisecting, and then you have to suspect fracture, condylar. So this can be an undisplaced fracture which you can miss. So this is one of the most important signs. So you have to go, you have to draw a line along the anterior humeral line, and this has to bisect. So this is how it is bisecting. So when it doesn't bisect, that means there is some problem, right? And similarly, the radial line, the long axis of the radial will exactly pass through the capitulum. So this is called the radiocapitular. So one is your radiocapitular, and the second one is your anterior humeral line, right? So these two are the important lines which you have to make out on the x-ray, because once you finish the case, then they will ask you what do you do. So we have to tell that we are going to take an x-ray. This is for the fresh cases what I'm talking about, not the malunion. It's a fresh case, right? So anterior humeral line and the radiocapitular line. Okay, and then I have told you that this is a fat pad sign. So directly in the second slide, I have showed you that there is a synovium, right? The extra synovial pouch is there, and the posterior aspect you will see there are two fat pads. So these are what I was talking about. So whenever you see there is an increased fat pad sign, whenever you see this thing on the X-ray, so this is a positive fat pad sign, right? Whenever you see this, again you have to suspect the fracture. So there is some abnormality in the supracondylar area, abnormality in the elbow joint, which is creating the effusion, and this effusion is filled and the fat pads, and this is X-ray like this. These are the important things you have to identify on the X-ray. Usually they ask you the fat pad sign, and then they might ask you about to identify the structures. So this is the anterior humerus, this is the posterior humerus, and this is your capitulum, right? And then this is your radial head. So if you see your radial head, and now this is your olecranon, your olecranon in the trochlear notch, and now this is your coronoid process, your coronoid process, this extension here, your coronoid, right? And this is your olecranon, and this is your ulnar bone, and now this is your, right? So this is about the identification of the bony prominence on the elbow on the X-ray, and then this is your fat pad sign. The posterior fat pad sign and anterior fat, right? So this is about the X-rays where they usually ask you about, and then they can put this X-ray as the spotter, and then they will ask you what is this condition. So we have discussed in the movements that there is one important condition where there is a restriction of both active and the passive movements on the X-ray. So that tells you that this is a bony restriction. So there is some bony component which is present in the joint, and that is called as your myositis ossificans. And why this occur? This usually can occur as a result of any elbow fracture which has gone for massage and stimulated the brachialis muscle, and that has resulted in the bony growth in the joint. And that is called as the myositis ossificans. This is a spotter, so they can put up this. And what is this? This is radial head replacement. So they have removed the radial head because there was a fracture of the radial head, and then they have put this radial head, the prosthesis. And now they had some problem with the brachialis, and this has resulted in the myositis ossificans, right? So the bone structure seen in the joint is the myositis ossificans, and most common joint to be involved is your elbow joint. So most common joint is the elbow, followed by your hip joint, right? And what is the treatment for this? The treatment of this is excision after maturity. So you have to wait until and then you go for excision. And how do patient present to you? Presents with restricted movement. Restricted, right? So this is the thing about myositis ossificans. And then they can ask you about one more important condition, which is called as the tennis elbow. What is tennis elbow? Inflammation of the common extensor origin. So that is your lateral epicondyle. So this is the lateral epicondylitis. So what is that? Lateral epicondylitis. And you all know the lateral epicondyle is the one which gives origin to all the extensors. So it is a chief extensor origin. So whenever there is an inflammation of this lateral epicondyle, it is called as lateral epicondylitis or the tennis elbow. How do we confirm it? We do a test which is called as the Cosen's test. Is called as the Cosen's test, right? And the second one you have to remember is the Mills maneuver. Second one is your Mills maneuver. So first is the Cosen's test. What do you do in Cosen's test? Again, elbow is in flexion as shown in the diagram. So you go for elbow flexion. And then you palpate for the lateral epicondyle. So this is how you palpate for the lateral epicondyle. And then what you do? Because it is a common extensor origin, you ask the patient to extend the elbow. So put like this, then you feel for the lateral epicondyle, then you ask the patient to extend the wrist. So on extending the wrist, you will apply the resistance. So whenever you apply the resistance and over the resistance, if there is a tenderness in the lateral epicondyle, it is called as lateral epicondylitis, or this is Cosen's test positive. Cosen's test positive. For example, your lateral epicondyle. What is Mills maneuver? Mills maneuver is flex the wrist on pronation. So flexing the wrist and on pronation again will cause pressure over the lateral epicondyle, and then you will have the lateral epicondylitis pain. So that is a confirmation of your what? Tennis elbow. So which tendon is involved? So it is extensor carpi radialis brevis tendon which is usually involved, right? And the treatment is usually you treat with NSAIDs, then you give rest, then you can also give a shot of local steroid injection. Local steroid injection, right? So this is the treatment: local steroid injections, and rest, and exercises after post treatment. You can give exercise. So recently there is also ERP which has been injected, so it is giving a result for. So again, this is about, they can ask you about your uh, tennis elbow in case of your elbow discussion also. Whenever they discuss, so they can ask you about Cosen's test, they can ask you about the Mills-Man. Okay, and then again you have your medial epicondylitis, right? You have your medial epicondylitis. So what is your medial epicondylitis? It is the involvement of your medial epicondyle, and it is called as the Wolfers, right? And again, students, elbow it is olecranon bursitis. And then they can ask you about cubital tunnel syndrome. So this is a cubital tunnel syndrome is nothing but involvement of your ulnar nerve whenever it passes between your both heads of flexor carpi ulnaris. Right, so these are the conditions, some of the important conditions which you have to remember, right from your supracondylar fracture humerus, myositis ossificans, lateral condylar humerus, tennis elbow, medial epicondylitis, student's elbow, and cubital tunnel syndrome. So that is about the examination of the elbow joint. Very, very important. And I have told everything in concise. So whenever you're going to the exam, so if tomorrow is your exam, orthopedic exam, then you can just go through this PDF. You can just listen to this your 30 minutes or 40 minutes, and then you will be ready to attend the exam, right? So any doubts you have? That is about the examination. Any doubts you can pin me on Insta. This is Dr. Alekhya Ortho, or you can ask in W Telegram app also. Right, so this is the clinical corner which we have come up recently, and you have all the cases which are there. So in case of orthopedics, you can directly click on ortho and you can see there are various cases like nerve injury you can learn, or the non-union, the malunion and all. Right, so that is about the elbow joint. Hope you have followed well. So any doubts you can ask me. Anything you want me to repeat, anything you have not followed. So hope this class helps you for learning good examination of the info. Remember all the important points and do well. Okay, see you all in the next class. Thank you.